Well, good afternoon. It is a blustery November day, and I just wanted to say thank you for joining me this afternoon. We are going to be talking about endometriosis and polycystic ovarian syndrome and some of the kind of nuances and ways to help manage those conditions. If you haven't tuned in before, my name is Babb. I'm a board-certified obstetrician gynecologist, and my practice is predominantly gynecology, sexual medicine, and menopause management. I am happy to be doing this video from Midwest City this afternoon. I'm in a hotel currently doing some moonlighting shifts over here, so I thought this would be a great time to join in and talk about some of these conditions because they are so prevalent, and we see so many women that come in complaining of things related to both PCOS and endometriosis as well. And the crazy thing about this is these conditions are everywhere. And you will, if you don't know somebody who either has PCOS or endometriosis, it's kind of a fluke. These are two disease processes that, most women across the United States, especially, either they themselves deal with or they know someone who has dealt with them. And yet there's still so much provider misunderstanding about the conditions, as well as not just in gynecologists, but in general medicine practitioners overall. So I wanted to try and kind of, shed some light on some of these conditions. I'm sorry if my lighting is a little bit funky. Hotel rooms are not the best. I don't know if that will, oh, now we just glare out. Now I look really old. Okay, there we go. Maybe that's a little bit better. So first of all, let's talk about polycystic ovarian syndrome, and then we'll talk about endometriosis after that. So for PCOS, really this condition came about or started really reaching kind of the minds of the gynecologic academicians in the 1950s. And it wasn't until a pair of physicians, Doctors Stein and Doctors Leventhal, kind of really put together this cohort of symptoms that polycystic ovarian syndrome came about. Now, if you look at current recommendations and current ways that we define the disease process, you have to have two of the three following symptoms. So number one is the presence of anovulatory bleeding. And what I mean by that is periods that are not normal. Some ladies who have anovulatory periods will say, well, they'll go, nothing, then they'll spot 1 month, and then they'll not do anything for another 3 months, and then they'll hemorrhage for a couple months, and they just bleed all over the place. These are the type of women that can't schedule this at all. They have no idea when their period's going to come. So that anovulatory bleeding, symptom number one. Symptom number two is the presence of increased androgens. So androgens are kind of more thought of male sex hormones, so things like testosterone, dihydrotestosterone, things along those lines. So women obviously are going to have testosterone too, but if they start having too much testosterone or too much dihydrotestosterone, they will start to have some symptoms of that. And then the third thing is the presence of multiple cysts or follicles on ovaries by ultrasound. Now, obviously, PCOS, it's kind of a funny syndrome because you only have to have 2 out of those 3. So you don't even have to have polycystic ovaries to have polycystic ovarian syndrome. So, whatever that is, kind of your little medical minutia of the day. But the fact of the matter is, when women come in, one of the most common, I guess, secondary symptoms that I hear from ladies that deal with PCOS is weight loss. Unfortunately, especially in Oklahoma, we do see a lot of polycystic ovarian syndrome women who are on the heavier side. And they will try and do everything. I mean, they'll diet, they'll exercise, they'll do all these things, and they're still unable to shed those pounds. And while that affects them from a physical and emotional appearance, it also can affect not only their ability to bear children, but also can affect some of their health in the future too. And the reason that a lot of these ladies have a hard time losing weight is due to a lovely hormone called insulin. Now, insulin, most of us know about with diabetics. You've heard of someone who has diabetes who has to take extra insulin, or they do things because their pancreas, which is normally where insulin is made, is not really functioning well. So those are your kind of type 1 diabetics or autoimmune diabetics. Now, patients that have type 2 diabetes, they are typically insulin resistant. And what I mean by that is their body may produce insulin, but because the tissues have become so used to it floating around, they don't really care about it. You know, it's kind of like training a dog. And if you keep saying sit, 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 it kind of starts to ignore you after a time. That's kind of insulin resistance in a nutshell. And so, you know, with that, there are a couple of different things you have to look at. So insulin as a hormone floats around our body, usually when we eat. That's kind of its big thing. You know, it's saying, oh, you ate something. I want to make sure your blood sugar levels don't get too high, because that can cause some problems. Well, in patients that have polycystic ovarian syndrome, especially if they are insulin resistant, then insulin will be floating around at such a high amount that not only does it interfere with blood sugar and things like that, but it also affects a bunch of other hormones too. So let's kind of take this clinical scenario, if you will. So a lady comes in, she has really heavy periods, they're all over the place, she never knows when they're going to happen, and she's noticed some signs of increased androgen. So she's noticed maybe some increased facial hair, or her skin's really oily, or she's noticed some acne, not just in kind of that T-zone, but also, you know, on her neck or her chest or things along those lines. And so she comes in, she says, well, you know, I've got these things, but I can't lose weight. What's going on? And so when we check those insulin levels, and we do that by, you know, having someone eat, and then we check an actual insulin, which is different from blood sugar, through a blood test a couple hours later, we say, oh my gosh, this insulin level is really high. Let's do something about this. And so a lot of times I have patients say, well, why does insulin matter with this? What's the big kicker? Well, so insulin goes in your bloodstream and in really high amounts inhibits the function of a hormone called sex hormone binding globulin, or SHBG. Now, if you've ever seen me as a patient for any type of sexual issue, you know that's one of the labs I check quite a bit, because sex hormone binding globulin, when it's really high, actually can inhibit a lot of free hormones, specifically testosterone. The flip of that, though, is when sex hormone binding globulin is really low, it can't pick up a lot of unbound hormones, specifically testosterone, dihydrotestosterone, and estradiol. Now, those three in a normal hormonal milieu, you know, serve a very good purpose, and they're very useful to have. But if you have too much testosterone floating around, what that does is your body says, well, that's nice, but let's convert it to this really active form of testosterone called dihydrotestosterone. And what does that do? Well, that causes hair follicles, specifically on your face, on your arm, on your chest, on your belly, to grow more hair, not mohair, grow more hair. But dihydrotestosterone is incredibly toxic to the hair follicles on your scalp. That's why men who have male pattern baldness typically will have a high level of dihydrotestosterone. And that's why medications like Propecia, which acts on the dihydrotestosterone conversion, work. They prevent that testosterone from going to dihydrotestosterone, and therefore it saves the hair follicles on your head, and therefore you don't get bald. Well, in women, especially if they have really high testosterone, they may develop male pattern baldness as well, or androgenic alopecia. And some ladies who have PCOS will come in and they'll have quite a bit of facial hair or hirsutism, but they'll also have bald patches on their head. And they say, well, I don't understand. Why do I have all this facial hair or this body hair, but my head hair is dying and going away? Well, it's due to dihydrotestosterone. So insulin, like I said, inhibits sex hormone binding globulin, which therefore leads to higher levels of free testosterone, which then get converted to dihydrotestosterone. Now, secondly, because we have higher levels of testosterone floating around, what that means is that cholesterol levels tend to go up too. And this is one of those hidden problems with PCOS that a lot of people don't know, is that women with untreated PCOS will tend to actually become hyperlipidemic, meaning they have higher levels of blood fats like cholesterol, triglycerides, things like that. And it's because they have those higher sex hormones floating around, and a lot of those lipids are actually derived from sex hormones originally. The third thing is, in peripheral fat, or adipose tissue, I guess we should be using the medical term, in peripheral adipose tissue, that testosterone gets converted into estradiol. So not only do these women have higher levels of testosterone, but their estrogen levels, or estradiol levels specifically, are also really high. And what that does is prevents the normal menstrual cycle kind of ebbing and flowing from happening. So in a regular menstrual cycle, we'll just say it's a 28-day cycle, divided in half. The first half is called the follicular phase, and it's very estrogen dominant. It's good. That's what we want. The little follicles on the ovaries are producing estrogen. They're kind of popping up until one follicle says, aha, I want to be ovulated. And it does. An egg comes out. Yeehaw. After ovulation, there is the second half of the cycle, or the luteal phase, which is really progesterone dependent. But if you have a constantly elevated level of estradiol, so instead of doing this kind of up and down, it's just kind of doing this hum, kind of going like this, you're not going to have the ability to ovulate. And that's because the release of a hormone called luteinizing hormone from your brain depends on a rise and fall of estradiol. And that luteinizing hormone is actually what triggers ovulation. So as estradiol goes up, it says that's great, it drops, and that drop signifies or tells your brain to release LH, and that triggers ovulation. So taking it back to our PCOS patient, she has a high level of circulating estradiol. It's not ebbing and flowing, it's just staying constant. So there's no way that she's going to have that ovulation because there's no drop in that estradiol. And that is why a lot of ladies have those really irregular cycles or really irregular periods when they have PCOS, and that leads to anovulatory bleeding or bleeding without ovulation. So that estradiol level is high, testosterone level is high, dihydrotestosterone level is high. It's all due to insulin. So what do you have to do? Well, you have to treat the insulin somehow. So there's a couple different ways to do that. So the textbook answer and actually the most effective way to cause weight loss, improve fertility, and help menstrual functioning is weight loss. So I guess you can't cause weight loss by weight loss. I mean, I guess you can, but weight loss is key. Now you say, well, that's great, Corey. You just told me that these ladies are taking, they're exercising all the time and they're eating right and they're still not losing weight. Well, why is that? Well, let's look again at kind of what's going on hormonally. So there are other times in a woman's life where estradiol is really high. Puberty is one. So it kind of goes up, it peaks. You get the development of breast tissue, you get start of period, you get things like that. You've got that period or that time right before ovulation. You've got pregnancy, and you've got some other hormonal times, just throughout the lifespan. Now, in a normally functioning cycle, these are very slight times. They're short. They're not meant to be forever. Anyone who's ever been pregnant does not want to be pregnant for their whole life usually. And so having that kind of high level of estradiol is fine. But when it stays high, what it does is it tricks your body into thinking you're almost in this quasi-pregnant state. And when it's doing that, it's very difficult to lose weight because you're wanting to keep everything stored on. Secondly, that high level of insulin floating around, if we take us out of this entire reproductive cycle and look at, say, we're being chased by a bear or overrun by zombies, whatever it may be, some sort of stressful situation, your body releases insulin as a way to conserve energy and help conserve fat so that when you need it, you have a source of energy and a source of calories. Well, let's take the average American diet. You're eating normally, you're not being chased by zombies, high levels of insulin floating around, and that insulin resistance means your body is like, well, I see we have all these calories. I'm going to store all this because high insulin means there's stressful situation. That's what your body thinks. Even if it's not stressful, it doesn't care. It's going to say, store everything. That's what we're going to do right now. So having that high level of insulin keeps those pounds on. So that's why the first thing, especially in insulin-resistant PCOS patients, we have to do is try and control that insulin. So you can do that with diet. So eating foods that are not white, not high glycemic index. You want like a slow burning type food. The American Diabetic Association website has a good list of foods that are, high or low glycemic index like that. The other thing to do is there are some other medications, metformin, glyburide, things like that, which are very helpful for ladies who have insulin resistance. Now, this is one of my big pet peeves with PCOS, is that you have some lady comes into her gynecologist and she says, oh, I'm PCOS. And the gynecologist says, oh, here you go, have some metformin. And it's like, well, you don't know if she's insulin resistant or not. If you give someone who is not insulin resistant metformin, whoopity freaking do. It's not going to do anything except give you diarrhea, which it kind of does anyway, let's be honest. So you really have to figure out, is this an insulin problem? If it is not, if it's something if they are not insulin resistant, then you have to target other things. So if they have high levels of androgens, target something on that. Because remember, going back hormonally, that high level of testosterone is getting converted into dihydrotestosterone and estradiol. So you have to take care of that testosterone. So some medications that are anti-androgenic, such as like spironolactone, which is a water pill, but you can use it for things like that, or there's some other ones out there, may be more beneficial for those ladies who are not insulin resistant. But the key, of course, is you have to test. So if you are a patient and you have PCOS and you're struggling with weight loss, you're struggling with really heavy periods, or some of the hormonal issues, the first thing you do is to go to your doctor and ask to have your actual insulin level tested. Remember, it's not glucose, it is insulin. And you eat something, a couple hours later, test your insulin levels and see if it's elevated. If it is, boom, insulin resistant. You need to be on some sort of insulin resistant medication to help control that. Like I said, diet can do it too. It's kind of a little bit of a harder battle just by itself, but either the ketogenic diet, some of the autoimmune protocol diets, things like that can be beneficial in reducing some of those things too. You just have to know that it's going to be a little bit of a trek. It's not an immediate type fix, unfortunately. I wish it were. Now, there have been some other treatments that people have used that have kind of fallen out of favor. We used to do a surgical technique called ovarian drilling, where especially if ladies had enlarged ovaries, we said, oh, you have tons of follicles there. They're not actually all, they're not being ovulated, they're just kind of staying around. And so we'll go in and we will actually take a little needle and bzz, 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 on the ovary and basically drain those follicles or drill on them. That was a little bit useful, but you're causing trauma to the ovary itself, so you really have to be careful about that. The other thing I sometimes will see is especially a lady who is PCOS who then goes and gets pregnant, and the question is, do we stay on that insulin sensitizing agent if she's on, say, metformin or glyburide while you're pregnant? And the answer is actually yes. That is something that is really helpful to do. Now, different physicians will have different ideas about this, but this is mine. This is mine only. We know that pregnancy is an insulin-resistant state. Around 20 weeks or so, the placenta starts secreting a hormone called human placental lactogen that increases insulin resistance in the mother. Similar to that whole idea of storing fat, helping to kind of grow the fetus, insulin has kind of a component called insulin-like growth factor, which can help with bone and muscle and other kind of tissue growth. And so when you have a developing baby, that can be very helpful as well. So the thing to remember then is that, like I said, if you have that insulin resistance and then you become pregnant, you are going to become insulin resistant anyway. But a lot of ladies are able to, counteract that. That's why not every woman has gestational diabetes. So my thought is to keep your patient or keep, the patients on that insulin sensitizing agent, because we know that it may lead to that insulin resistance while they're pregnant. Now, I saw that someone posted that they took me off the metformin as soon as I was pregnant, said it can mask gestational diabetes. Well, there may be a little bit of truth to that. The thing, though, you have to look at is that if you are already insulin resistant, is this something that you want to do your typical 1-hour screening test for? Usually that's done between 26, 28 weeks or so. Really, that's testing for that insulin resistance. That's what it's really doing, kind of seeing how your body's handling it. So in ladies that you have a concern that they may actually become already gestationally diabetic or already just overtly diabetic, you can actually take that screening test, move it a lot sooner. The other thing to do is, and some people will check as a lab value called a hemoglobin A1C. And what that does is it measures your average blood sugar over the last 3 months. And that's kind of an interesting little balance there, because first of all, you know, let's say your blood sugar was 300 every month. It's going to give you on average, it's going to give you, you know, a value based off of that. Now let's say that for 15 days out of the month, your blood sugar is 150. And for the other 15 days, it's 450. Well, that kind of averages out to be 300 roughly. And so you're still going to get that same hemoglobin A1C value. So you have to be careful about that. Because, you know, it's not kind of this end-all be-all, you know, test value like some people use. Now, obviously, if you have a hemoglobin A1C that comes back crazy high, like 10 or 12 or bazillion or something like that, yes, definitely there are issues with that. But if it's like, well, it's 5, or maybe it's slightly elevated, you know, you may want to consider doing some of those other tests just to really see. And, you know, exactly, Sandra, some people said they've had GTT as soon as 12 weeks. You know, now if you do it prior to that 20-week mark, you're not going to get the effects of human placental lactogen in there, but it still can be beneficial, especially if you have a patient that has a very strong family history of diabetes. She herself has had gestational diabetes in the past, so on and so forth. But remember, I mean, honestly, for the vast majority of ladies with PCOS, the big kicker is, are you insulin resistant? That is the #1 question that I ask when I diagnose someone with PCOS. The second thing after that is, well, where are you in your life as far as what you want to do? Do you want to, are you worried about fertility? Are you worried about weight loss? Are you worried about the kind of physiologic or physical changes, you know, the increased facial hair, the acne, things like that? And you can treat all of those things. You just have to know and you have to understand how the disease process works. And that is the key. And really, it's fairly straightforward, honestly, if you just understand hormones. But that's, I'm going to leave that. So we're going to switch gears a little bit now, go to endometriosis. Now, endometriosis is this crazy condition. And, you know, people make their entire careers out of treating endometriosis. And so what it is, if you've never heard of it before, is basically the presence of endometrial or tissue, which is tissue from the lining of the uterus or the endometrium, that is somehow outside of the uterus itself. And it can be on the abdominal wall. It can be on the colon. It can be in the rectum. It can be in the stomach. It can be in the brain. It can be in the lungs. It can be anywhere. You know, you could be walking around literally and have a scar on your forehead, in theory, that had an endometriosis spot on it. That would be nuts, but it could happen. And so the question that a lot of people have is, well, how does this happen? How does this occur? Well, so first theory, Sampson's theory, was basically that with a normal menstrual cycle, remember, so here's your uterus, I'm your uterus, you got your tubes coming out here, they're attached, and they got these little finger things on the end called fimbria. And there is an open connection going down the center of the fimbria to the uterus. So here we are, I'm a uterus, I'm walking around doing my thing. Oh, it's time to have a period. Blood starts kind of collecting from the endometrium, and most of it goes out, down through your vagina, right? But some of it, the thought is maybe it goes back up through the tube. And so you have this thing called retrograde menstruation. And the thought with that is that that endometrial blood goes out of the tube and then will implant, because it has those endometrial cells, somewhere, wherever that blood hits. So that's a good thought. I mean, it makes sense logically. Like, we can see it. I've done surgery before when a lady's on her period, and you say, oh, look, there's blood coming out of the tube. Ba-da-dum! You've seen retrograde menstruation. Now, there are some other theories about how it happens due to kind of way we develop embryologically. And the sum of it basically is that you have tissue that was supposed to be endometrial that, through whatever reason, migrates away from the uterus. And so instead of staying inside the uterus, it develops as this endometrial tissue in another organ. You know, maybe it's on the stomach, maybe it's in the bowel, whatever. And so this kind of theory is called Coelomic metaplasia. That's kind of the big thing with that. And since I'm on call, I have to take this call. I will be right back. We're back. Sorry, when I do these, I'm usually kind of doing a moonlighting gig or things along those lines. So obviously I can get phone calls in the middle of it. So I apologize for that interruption, but we'll kind of continue on here with where we were. And thank you if you're just tuning in now. We have been talking about endometriosis, and we'll kind of pick up where we were with that. So, we were talking a little bit about coelomic metaplasia, which basically is the idea that this tissue from an embryologic standpoint migrates and goes into a different organ or a different portion of the body. And that can be, like I said before, the lungs, it can be on the diaphragm, it can be in the colon, it can be wherever it may be. And the interesting thing about this is that you'll have ladies that will come in and they'll say, well, every month when I'm on my period, I vomit blood. I have rectal bleeding. I get these really bad headaches. I cough up blood. I have all of these crazy symptoms. And obviously those need to be investigated, but I personally have seen patients that have had endometriosis lesions on their stomach, in their rectum, and then on the diaphragm as well. And they all have these kind of other associated symptoms with it. So anyway, so that's kind of an overview of what endometriosis is. But the big question next is, what do we do about it? So when you're looking at endometriosis, the kind of stereotypical presentation for this condition is a lady that comes in that has this clinical triad of painful periods, painful intercourse, and then pain having a bowel movement while she is on her period, or dysmenorrhea, dyspareunia, and dyschezia. What that means is that because that endometrial tissue, wherever it may be, inside the uterus, if it's on the side or inside of the abdomen, and wherever it is hormonally active. And it is receiving those hormonal stimulations that the normal endometrial tissue that's inside the uterus is getting. And because it's getting those, it is bleeding. And blood is really irritating to tissue outside of blood vessels. So if you have bleeding inside your abdomen, it hurts. If you have bleeding inside your bladder, it doesn't feel good. If you have bleeding, blibbity blobbity blue, wherever your blood is not supposed to go, it is really uncomfortable. And so that's one of those, the reason that those periods are really painful, or that they have pain, having a bowel movement, or if those endometriosis lesions are in the bottom of the abdominal cavity or are on top of the vagina, why intercourse can be really painful with that as well. So that triad of painful intercourse, painful periods, and pain with having a bowel movement is kind of the classic presentation for ladies that have endo. But this thing is, a lot of other women will present with other symptoms too. They'll say, well, my periods are really heavy as well. They're not just painful, but they're super duper heavy. Or I kind of will have some kind of emotional changes, more so around the time of my period. So some of these kind of PMS-like symptoms that may be a little bit aggravated. And so you have to really piece this together to kind of see. Now, the frustrating thing with endometriosis currently is that we do not have a good way of diagnosing it outside of direct visualization of the lesion. And what I mean by that is I can't order a CT or an X-ray or an ultrasound or whatever it may be and see those endometriosis lesions. With very specific weighting on an MRI, and that's weight, like W-E-I-G-H-T, on an MRI, you can sometimes pick them up, but that is not, it's not the gold standard. Unfortunately, the gold standard for diagnosis is to actually visualize the lesions with surgery. So the next question then is, well, what do you do if you think you have endo? So you have a couple of different options. Exactly, endometriosis, people have had anemia or pica from the amount of blood loss. And pica, if you don't know what that is you have this urge to eat things that you wouldn't normally eat, like clay or dirt or comet or whatever it may be, ice, chewing, some people will say. So the first step in treating a lady who has endometriosis is figuring out what is her end goal. Is she dealing with more pain control, or is it more fertility? Those are the two big things that we have to look at. For fertility, study after study after study has demonstrated that really the only way to increase fertility, because the presence of endometriosis by itself decreases your fertility rate by approximately a quarter. Now, that's a very rough number, but roughly 25% reduction in spontaneous fertility just by having endometriosis. And so study after study has shown that really the only way to temporarily fix or reverse that is with surgical excision of those endometriosis lesions. Now, that gets into a whole hot button topic, which I'll talk about here in just a second, but basically you have to get rid of the lesions themselves. You can throw as much medication as you want at it. You can try and decrease the size of the lesions. You can try and help hormonally control them. But really, the only way you're going to help with fertility is to actually take out the lesions themselves. Now, we'll get to that in just a second, but let's flip over to pain control. So now you have a couple of options from a pain side of things. Number one is treating the pain by itself. Now, in Oklahoma, if you are listening from a different state, we had a couple of opioid laws that went into effect recently that make it really difficult to prescribe opioid-type narcotics for things like endometriosis. So we're really having to use a bunch of other medications to try and help reduce the discomfort with this condition. Obviously, non-steroidal anti-inflammatory medications like your ibuprofen or your naproxen or things like that can be beneficial, maybe kind of like a drop in the bucket for a lot of ladies that have really bad endo. Other things, like I said, there are those things like Ultram or Tramadol or oxycodone or hydrocodone or things kind of along those lines, which can be beneficial, but you're really just bandaging bandaging, not band-aiding. That's, I just use a trade name for something. You're bandaging, there you go, the condition itself. You're not really helping it. So a lot of women will elect then to try and do something hormonally. Now, we've got a couple of different options with this. The old reliable has been birth control pills, specifically oral contraceptive pills. And the way that does, it basically tricks your body into thinking you're pregnant, very loosely. And so those endometriosis lesions do not get that surge, that ebb and flow of those hormones. So that's great. The other option that we have, or one of the other options, is by using a medication called Leuprolide or Lupron. And what that does is basically goes to your brain and shuts down the release of these hormones called gonadotropin-releasing hormones from your brain. And if you shut down that GnRH, what that does is it basically puts you into a medical menopause. And so, much like with birth control, those lesions are not receiving any type of hormonal influence, and so the thought is then that they will kind of regress and go away. Now, there have been a couple of new medications that have come out recently that are treating endometriosis in a similar way, but don't have the same side effects. Honestly, I've put a couple of patients on those. Orlexa is one of them, and I've had a hard time getting insurance to cover them or to cover it. But that's another, it's one of the kind of the new drug that's out, and it has kind of a moderate strength version if you don't have dyspareunia or that painful intercourse, or a high strength version if you do have dyspareunia. So that's something that is out there, but I can't really speak from personal experience just because I haven't been able to get anyone to have insurance prior authorization to be able to have that medication, which is really stupid. There's another medication called Danazol that we hardly ever use because it typically would cause ladies to grow facial hair, pretty impressive facial hair. So if you want a beard like mine, then Danazol may be an endometriosis medication for you, but it actually works pretty well. It just has a lot of bad side effects. So I can think of one patient I've had in my entire career that we put on Danazol. She was at that point, that she needed something done. Obviously, definitive therapy for pain control with endometriosis from the lesions themselves is excision, and then unfortunately you're looking at basically putting a patient into surgical menopause. And what I mean with that is taking out both the uterus and the ovaries. Now, some ladies will go and will have just a hysterectomy where you remove the uterus. And that will, in theory, help reduce the formation of any new endometriosis lesions. But the overwhelmingly vast majority of women that have a hysterectomy but save their ovaries end up having their ovaries removed for endometriosis within a few years because the disease comes back. So it's really kind of frustrating with that. That's something that if that's a direction you want to go down, you really need to make sure, am I finished having kiddos? Am I, prepared to kind of deal with some of the menopausal side effects that go along with that surgical menopause? And obviously these women can go on hormone replacement therapy. That's not a problem, but you have to kind of give it almost a hormone holiday, to shrink it. So they will have some hot flashes, night sweats, things like that right after the surgery, as we let things kind of get back to, a low hormone hum. So unfortunately, that's kind of the main stuff we have for pain control. Now, fertility is a whole different ballgame, because obviously, you're taking the whole removal of the uterus out of the picture, and you're looking at, do we go in and do we ablate? And by means of that, I say take a laser or take cautery and zap or fry the endometriosis lesions, or do we actually excise or cut them out, those lesions? And that's kind of a little bit of a matter of debate. The people that are who are done training in minimally invasive gynecology, where they go and they do an extra year of fellowship and to really use the operating robot and things like that to help deal with these things, will say the best thing to do is to go and excise the lesions, actually take them out. Excuse me. I'm just getting over a cold. Okay. And that's great. And a lot of times you can do that, especially if you have isolated lesions. 100% completely agree. The problem is there aren't a lot of MIG or minimally invasive gynecologic centers throughout the country. And so if you're someone who's in kind of a small Oklahoma town and you have just your run-of-the-mill gynecologist, they may not feel comfortable going in and excising those lesions. So what can you do with that? Well, you can use something like an operating laser or cautery to go and fry them, but you have to make sure that you have an adequate depth of cauterization or ablation of the lesion. Going and burning the surface won't do it. You actually have to penetrate into the endometriosis lesion itself and then cauterize it from the inside out. In some ladies, like I said, with just one or two lesions, I'll excise them, especially if they're easy to get. And, if it's not on the bowel itself or on the ureter, which is a tube that goes from the kidney to the bladder, I'm fairly comfortable excising them. But if you have extensive lesions that are all over other organs, then ablation is typically what we'll do, or with follow-up with one of the minimally invasive gynecologic centers across the country. There's one in Dallas, there's one in Nashville, and then some of our reproductive endocrinologists here in Tulsa are really comfortable doing those surgeries too. So if it's something that looks like really severe endometriosis, for pain control or for fertility wise, I'll typically refer to them for surgical management, just to make sure, because obviously the goal with this is helping you get a baby. And I learned a long time ago to kind of check your, ego at the door when it comes to surgery. So that's kind of the gist of that. It's a condition that is very prevalent. And unfortunately, a lot of women will suffer with those symptoms because they're kind of a little bit vague. You say, well, my periods are really painful, and yeah, it sometimes hurts when I have sex or things like that. But if this is something that is persistent to where every cycle you're like, man, I am missing school, I'm missing work, whatever it may be, sex is excruciatingly painful, and there are these other weird symptoms too, it really behooves you to go and get evaluated and get checked out. So, trying to remember if there were any other endometriosis questions that we had before. But in the meantime, if you have any questions, I know some people have kind of chimed in here and there, please let me know. I'm happy to talk for just a little bit longer. Let's see here. I think that's pretty much it. Okay. Alrighty. Well, So that's all that I have, I guess. I don't have any other questions. Like I said, feel free. Oh, here we go. Could symptoms of this arise after a C-section? As far as endometriosis, is that what you're talking about? The answer to that, it can be yes. You can actually get endometriosis in cesarean section scars. The other thing that can go on is that there's a kind of a side condition called adenomyosis, which is the presence of that endometrial tissue within the muscle of the uterus. What I mean by that is that you know, having the muscle there, getting that endometrium in it, it's going to react to that menstrual blood, and it's going to be really, really irritating. And so you will have exquisitely painful periods and really heavy bleeding. But with adeno, you typically don't have any pain outside of outside of your period. Now, that's something I didn't say about endometriosis that is really important to think about too, is that a lot of time the pain persists regardless of where you are in your menstrual cycle, because as that blood is accumulating and that kind of chronic inflammation is happening within the pelvis or wherever it may be, your body says, ooh, that's an irritant, I need to do something about it. And so it forms scar tissue around it. So a lot of women will have scar tissue bands or adhesion bands all throughout their pelvis due to endometriosis. And much, you know, for surgery, or excuse me, for pain or for fertility, you really do have to have those removed to kind of give you the best results going on. So is Vanaquah safe while nursing? So Vanaquah is a medication. It's a fluornithine. It's kind of a topical hair remover. We'll sometimes use it for ladies that have increased facial hair or body hair. You know, the actual mechanism of action of it, you know, a lot of the topicals are safe. You know, I honestly have no idea specifically. I'd have to look that one up for you. I would think so, just because, like I said, it is a topical and you're kind of applying it to this a target area. You're not taking it systemically. So I would say yes, but I would definitely do, you know, kind of check and see. What if you don't want kids anymore? Previously, or being treated with metformin PCOS? Should I be asking my midwife at my 6-week postpartum visit about some sort of treatment? The only thing I'd be interested in is weight loss and things like facial hair, etc. So, yeah, the thing you have to remember too about PCOS is that not only do you have kind of the fertility side effects, but the things like the hirsutism and the weight gain and things along those lines, you know, persist and should be treated regardless of where you are in your cycle. The other thing is that ladies who have long-term PCOS, especially if it goes, you know, untreated, are at a higher risk of developing endometrial cancer because they have so much unopposed estrogen. So women who have PCOS that are not on any type of treatment, if they start having really irregular bleeding, especially really heavy bleeding after the age of 35, we'll sometimes do additional testing on them. And especially if it happened around menopause or after menopause, they start having a lot of postmenopausal bleeding. You know, that's definitely something you want to be concerned about. So yeah, so the non-sexual side effects, non-sex hormone related side effects of PCOS, weight gain, potential for endometrial cancer, potential for increased lipids and fats in your body, and like I said, some of the hirsutism, facial hair, things like that. So any other questions? Give it a couple minutes. Oh, if the endometriosis affects the legs and feet after having it removed, can it still bother them? So if it's removed, will it still have those same effects? I think that's the question that you're trying to ask there, Hillary. And so, you know, if you have a endometriosis lesion that is on some sort of neurovascular plexus or is on some sort of irritating some nerves, then having a shrinkage of that endometriosis lesion or getting it excised should reduce any type of neuronal or neuronal inflammation. So treating the endometriosis should cause a reduction in those symptoms in things like your legs and your feet and stuff like that. Yes, that should be the case if it is due to the endometriosis. So if you have, let's say, a lady that has hysterectomy, ovaries removed, everything's out, not any type of hormone replacement therapy, she has endometriosis, and those symptoms still persist and may not have been due to the endometriosis. Pelvic tenderness regardless of where you are in your cycle, no heavy periods, sex uncomfortable, lower abdomen always tender, regular bowel habits. Post C-section scar tissue, inflammation, what are the possibilities? Okay. So pelvic tenderness, so there's a lot of stuff that can go on there. Obviously, if you have had a cesarean section or any type of abdominal surgery, you're exactly correct in that pelvic pain can be due to post-surgical adhesions. As much as we'd love to say that we have perfect surgical technique and everyone's going to heal amazingly, the fact of the matter is greater than 90% of people, if they have surgery, will have scar tissue internally afterwards. So that is definitely a consideration. Second thing is, if you have ever been pregnant, you have a potential of having some pelvic floor dysfunction. Honestly, if you wear high heels, you have the potential of having pelvic floor dysfunction. If you have, chronic cough, if you're chronically constipated and are straining a whole bunch, you have the potential for pelvic floor dysfunction. So that is definitely one thing that needs to be evaluated is, is that pain due to a muscle spasm within the pelvic floor itself? And just like if you have a muscle spasm in your shoulder or your arm and someone comes along and is pushing it and you're like, please stop, that hurts. If the vagina is spasmed and the penis comes along and it's like poke, 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 or whatever it may be that's going in there, that can be really painful too. Now, if the abdomen is always tender, I'd want to know, it's like I said, is this something that's muscular? Do you have some sort of chronic inflammation that's going on from something else? Is it a scar tissue? The always tenderness is a little bit more puzzling than, provoked tenderness, something related to sex or your period or whatever it may be. So I definitely think that's something that, should be kind of investigated and kind of see if there's something to be done about that always tenderness there. All right, probably got time for about one more question. As always, if this is your first time tuning in, I've got a lot of other videos on here. You can watch my hair grow over the last year. And then if it's something you'd like to, if you're not a patient and you'd like to have more time, more specific time, I have our office number on the Facebook page site, and you can give that a call, and I'll be happy to sit down and talk with you, one-on-one. So otherwise, I think that's going to be it for me. Thank you so much for tuning in today, and I look forward to chatting with you later on. So have a wonderful day and a good weekend. Bye-bye.